Broadcasting from the world headquarters of the National Floor Safety Institute is America's slip and fall guy, Russ Kenzie.
This is America's slip and fall guy, Russ Kenzie. Thanks for listening to my podcast. We all know that falls aren't funny, especially if you're the person who slipped and fell and got hurt. Well, we all know that if you're hurt, you wind up going to either an emergency room or a family doctor or emergency care facility in your community to see what actually happened, what you actually broke. And joining us today is Dr. Howard Harris, who's an orthopedic surgeon at Texas Orthopedic Specialists. Welcome to the program.
Thank you for having me.
So we're going to talk a little bit about the people that come in to your clinic, to your office, who've been victims of a slip and fall, which you probably see a few every now and then. Tell us, first of all, about your practice, about yourself, your background, what you do.
I'm an orthopedic surgeon and have fellowship training in both orthopedic trauma and orthopedic sports medicine. Been practicing in private practice for over 16 years in the Dallas-Fort Worth area. My practice now is mostly elective, but we still take care of patients from injuries that get sent from the hospital or get called from the hospital, as well as patients that schedule appointments to come in as an outpatient for evaluations for orthopedic injuries. Specifically for me, mostly upper extremity, a lot of shoulder injuries, but also some knees and lower extremity as well. And my practice takes care of everything orthopedic in the upper and lower extremities. So we see that across the board with myself as well as with my partners.
How many partners do you have?
There's 8 of us total, recruiting for more. It's fortunately a growing specialty and a growing community that we're in.
Nothing driven by falls, I'm sure.
That is a problem.
Well, tell us a little bit about the people that come into your facility who are hurt. Average person, average type of injury. I mean, what's a typical, if there is such a thing, a typical victim or injured person that would come into your clinic for needing treatment?
Well, there's really not anything that's typical about it. The injuries that people sustain, particularly from falls, sort of transcend all walks of life. Gravity doesn't pick on anybody in particular. It picks on everybody. And so, the elderly obviously have a higher incidence of injuries with falls, but, we see, both male and female, older, younger, different genders, all socioeconomic classes, that they can get injured. So the problem we have in our industry is we deal with the reactive part of the problem of injuries. As an orthopedic surgeon, we really can't prevent people from getting injured very effectively, but we deal with it after it's occurred. So the problem we have in the society is the increasing elderly population is driving an increased number of injuries, and there's not anything from a orthopedic surgeon perspective that we can really do effectively to prevent those injuries.
So somebody comes in your office, maybe an elderly person, maybe with a son or daughter who's bringing them in, and what's kind of a expected injury? Is it a shoulder injury, arm injury, hip injury? You hear a lot about broken hips in the elderly. What's the most chronic injury? The
most common orthopedic injuries from a fall, particularly in the elderly, are hip fractures, distal radius or fractures at the wrist, as well as proximal humerus fractures. But head, not an orthopedic injury, but head injuries are very common. Closed head injuries are very serious and a lot of times lethal problems that the elderly have, especially if they're on any kind of anticoagulants. The risk of complications from a fall are much higher in those patients that have other medical issues.
Right. Now, obviously, if somebody broke a hip, an elderly person broke a hip, they're not waiting in your office. They're going to an emergency room, right? Emergency care center, someplace requiring emergency treatment.
Yeah, that's typically a call from the emergency room physician to me or one of my partners to see a patient that's in the ER because they've fallen and sustained a hip fracture and they've been transported usually from emergency services like an ambulance EMS services to a hospital because they're not able to get up or move or get into a vehicle on their own.
And I can imagine very painful.
Typically very painful.
Yeah.
And requires surgery in most cases.
There's been this, I don't know if it's a wives' tale, maybe you can dispel it, but oftentimes I'll hear, especially in matters involving litigation, that the reason for the person's fall was not because they fell and broke their hip, but their hip spontaneously fractured because of their age or some potential bone disease, and therefore the fall was a result of them spontaneously breaking their hip. Obviously, this is a defendant's defense oftentimes, is to say, well, the fall was actually secondary. Do you see any evidence of that in your practice where people have spontaneous hip fractures?
I don't see that. A vast majority of hip fractures, for instance, occur like most other fractures from a fall is the sudden stop at the bottom. I mean, it's when you hit the floor that causes that fracture. Outside of some pre-existing pathologic process like a cancer lesion or a metastatic lesion in bone that would create a weak area, those patients they're more susceptible for fracture, but a fracture occurs when you fall and hit the ground that causes the wrist fracture or the hip fracture or the shoulder fracture. So it's a bit of a myth that patients, hips break and that causes the fall. It's the fall that occurs that causes the hip fracture.
Right. So you get a call, elderly patient at the hospital needs your attention or one of your partner's attention. Kind of walk us through what's the process. You go in, you do your examination, I guess x-rays, all the diagnostic tools are used, and you have to tell somebody they have a fractured hip that requires immediate surgery. Is that typical?
Most of the orthopedic injuries we deal with, hip fractures, shoulder fractures, distal radius fractures, they are typically done on an urgent basis. It's not a life-saving type surgery. So, those are done usually later that day or the next day, because typically those patients have medical problems that you have to address first. So you have to make sure they're medically stable enough to go to the operating room to have a surgical procedure done. And so that's a process, and it's not a simple elective procedure in and out the same day. This is a life-changing type event. Usually these patients have other medical comorbidities, they have other risk factors, so it creates a scenario where medicine or medical consults are needed and anesthesia evaluation is needed, and then they proceed to having the surgical procedure. And then the hard part really is the recovery. The surgery's something that happens relatively efficiently in most cases, and then they've got to recover. They've got to heal. Most of those patients, particularly with hip fractures, lose a degree of mobility. So if they're independent ambulators, they become after that heals without complications, still limited, say, in ambulating only at home. Or if they're ambulating at home, they have to use a walker. If they're using a cane or a walker, they have to start using a wheelchair periodically. So it's a life-changing in the sense of they lose mobility, and it creates a lot of psychological issues where those patients now have a fear because they've gone through this process from usually obviously unintentional, but usually inadvertent fall that has created a problem that has changed their life, and they're afraid of falling again because they know what the repercussions of that are, and dependency on family members. The impact on the children or grandchildren and caregivers that a lot of the independent elderly don't want to be dependent on someone else for their daily activities, and so that it's a ripple effect that doesn't just involve one person at one time. It has an impact on a lot of people over a long period of time, and then the real unfortunate event is, with hip fractures, since that's what you ask about a third of those patients, 30% of them are dead within 6 months.
Really?
The fatality rate after a hip fracture is very high in our elderly population, not because hip fractures are fatal events. It's the medical complications and comorbidities that come along with those problems. They die of pneumonia, or they die of an infection, of some other sort, or cardiac event, or the physiologic stress that you go through to recover from an injury in a surgery like that puts stress on the individual where they're not able to recover.
Now, is it true, the older you get, the less of a candidate or the higher the risk there is for surgery? I mean, you reach a certain age due to anesthesia and other effects of the surgical procedure that may actually just raise the risk real high?
Age correlates with a lot of medical problems that do have an associated risk for surgical procedures, for anesthesia. A lot of that really is maybe more accurately looked at physiologically as opposed to chronologically. There are patients in their 60s that are terrible candidates for surgery, and there are patients in their 80s that are low risk for surgery because their medical condition otherwise. And that's a lot of times pulmonary issues, cardiac issues, cognitive issues. The having dementia increases your risk of problems after surgery because of the ability to comply with instructions and limitations that you may have.
So we're getting old. The country's getting older. This is a big problem for the country, specifically for the elderly. We were talking about this earlier. The number of people, how many people seek emergency room treatment for a fall and die?
I think for falls alone, it's somewhere in the neighborhood of 8 million people a year visit our ERs, our community ERs, and so it's a huge task on the medical system to deal with slip and fall, trip and fall injuries, and those it's tens of thousands of dollars for a lot of those events, and so it's an astronomical financial number as well, and that translates into, I think it's around 30,000 people a year that die from slip and fall injuries. Wow. And that's related to the medical problems they have, either from the injury or like a head injury, a subdural bleed has a high fatality risk, and particularly in our elderly. But those dollars are not being used in the medical system for other problems, research for diabetes or cancer or other medical problems in our system in our population that have the potential for cures or for more advanced technologic treatment options. We're spending a lot of resources on dealing with potentially preventable problems and injuries from falls, and hundreds of millions, if not billions of dollars a year.
Right. How much does an average hip replacement go for these days? What's kind of the expected cost?
I think the average cost of say a hip fracture, a patient that has a fall, goes to the ER, has surgery for a hip fracture, and the follow-up care, that average cost is somewhere around $35,000, and that's without complications. If you have, let's say you have a heart attack from the physiologic stress of going through that process, and intensive care unit stays, you can quickly get into the six figures or more for medical care for something that was a preventable injury.
So that's a big cost to Medicare. I mean, predominantly paying, I presume, for most of this in the elderly population. Is that a fair statement?
Well, our Medicare predominantly, our elderly population is predominantly on Medicare. But it's also a huge workforce cost. I mean, this is not just an elderly problem. The work comp claims are top three in almost every sector of industry are slip and fall related. Yeah. So those are lost wages, lost productivity hours, and permanent loss of function in some individuals where they have to either lose employment or seek alternative employment. And then the medical care associated with that too. So it's a huge tax on Medicare for our elderly and their family members, but also on our workforce that sustain injuries at work and go through the work comp system.
So if we kind of split it out, we talk about elder falls, and then younger falls, younger meaning less than under the age of 65 or 60, whatever they claim being old is these days. It kind of changes. It's a moving target. But, if you're an elderly person, you break a hip, you go to the hospital, you have surgery, many of these people wind up having to go to nursing care, right? I mean, it's common for many people who have been injured to that level, to that severity, to need care, additional care. They can't care for themselves.
That's what I mentioned earlier, that loss of independence. Patients that are independent livers at home end up having to have in-home care, or if they're at that level already, they end up in a skilled nursing facility or a nursing home type facility with a higher level of assistance needed, which comes at a higher cost to somebody, either to the taxpayers or to the family members or to the individual. And the shame of it is those patients are that much higher at risk of another injury. Statistics of upwards of 50% of nursing home residents fall annually, and that's annually. So they fall again, and so it's for a lot of people, it's a matter of time before it's their turn. If you're in that 50%, and a lot of those falls end up with some type of injury.
So, aside from the cost, which is astronomical, just going up, because our population is getting older, the impact on the family, what do we do with, mom's house since she can't live there? What do we do with the dog? I mean, there's a lot of impact on, as you mentioned a moment ago, the entire family. I mean, the surrounding, I don't want to call them victims, but individuals that have to really make decisions now for their mother, aging parent. Maybe they're married. And so, mom's in a nursing home with a broken hip injury. Who's going to care for dad? And that's almost like a counseling part of medicine now, isn't it?
We deal with individuals in providing medical care. It's not just a business of customers and an organization or a corporate entity. It's a physician and a patient and their patient's family, because those individuals are all involved in most cases impacted by the decisions that individuals make for their medical care. So there is an element of counseling and providing care for the patient and for the family and guidance through a process they don't want to be involved in and that they didn't choose to be involved in, but it's been somewhat inflicted on them. So rarely does anyone show up to the orthopedic surgeon because they want to see us. They show up because they have to for typically an injury of some sort. And so that helping them through that process is what we enjoy doing as physicians, providing that level of care, but helping their family and giving them guidance and instruction on how to try to restore a level of independence and a level of quality of life that they would want.
Right.
Is more than just doing a surgery and sending them on their way.
Well, we're living longer. We're working longer. It used to be people retired at age 65. It's not uncommon to see people even through their 70s working. So you talked about workplace injuries. Let's spend a minute talking about younger victims, people who are much healthier, better level of fitness, and those kind of people that come into your clinic that you have to treat. Give us some idea about those folks.
Well, that's it's a problem that occurs a lot of times in the workplace, which is the work comp related items I mentioned earlier, but also a lot of people that are working are also very active, and so fall injuries outside of the workplace lead to injuries that impact the workplace. And so they have families, they have children, individuals that work at the facilities that provide us home goods and are plants and warehouses that stock and deliver things to our communities. All those individuals have to have the ability to climb ladders and to lift and carry and push and pull. And when you fall and have a distal radius fracture or tear a rotator cuff or slip and break an ankle, you may be out of commission from a physical demanding job, if it's at the post office or at a local hardware store or whatever, for anywhere from 6 weeks to 6 months. And if you have a wife and 3 kids at home, and you're the primary provider for them, and you have 6 months off because of an injury, that's a substantial impact on you and your dependents, as well as the community that you live in.
You told me a story several years ago. You may want to share it. A friend of yours, a musical minister who broke his hand on a slip and fall, right? Or broke his arm. And the impact it had on his life. Now you think, well, was it an arm or wrist?
Was it his shoulder, proximal humerus?
Well, I was getting there. But that's kind of a typical, unusual kind of story, right?
Professional musician, played at the professional level, but also worked in ministry as a worship leader, a concert pianist, vocalist too, and scratch golfer. Very very high functioning, very capable individual. Slipped on the paint on a wheelchair ramp outside that was wet from rain. Slipped and fell and sustained a proximal humerus fracture that required surgery. The ball of the shoulder joint was broken into several pieces and had to be repaired. And that guy stands up in front of thousands of people every Sunday, with his arms over his head. And I've taken him out of commission, with the restrictions we put him on after surgery, from basically playing the piano and doing his job at his local congregation, and obviously his recreational activities as well were impacted by that. And it was months before he was able to return to work and service and a lifestyle that he was accustomed to.
How about real young victims? You see any children? Is this we keep talking about the elderly. I want to kind of get back to, this affects all people at all ages, is what I'm getting at. Is that right?
It does. The injuries change. Hip fractures don't occur in our commonly anyway in our younger patients because bone density is different. The susceptibility to falling and the mechanism is different in younger patients. Fortunately, our really young people are more durable when they hit the ground.
They bounce.
But the potential is there. For work, particularly workplace injuries. Younger, more healthy, more active individuals tend to be in more dangerous environments. A lot of times, there's not a lot of senior citizens that are working on the floor of a meatpacking facility per se, and so the injuries are in our agricultural industry. The injuries from a fall around heavy equipment and around machinery usually can be a lot more devastating. Loss of life, loss of limb that can occur from those type of injuries, and particularly in the workplace.
Well, a lot of people say, gosh, it was just a fall. Come on, how seriously injured can you be just from a fall? Kind of get up and you're all right. We were laughing about it. When you're 16 and you slip and fall, you're embarrassed. You get up, go about your way. When you're 40, you fall, you get up a little slower. May take a day or two off of work. And when you're older, 60s or 70s, you fall and you break, and you don't usually get up. Or if you get up, it's a much more serious injury. So there's kind of this chronology of age related to the severity of the injury. But in your practice, is this really that big of a problem?
I primarily, in my practice, see almost exclusively upper extremity injuries now, and it's all elective. And so it's patients that are coming to me not from the hospital, but a lot of times they've been to the hospital, and then they come see me because of my practice. And it's weekly. I see usually multiple patients every week that have sustained a proximal humerus fracture or a shoulder injury, or potentially an elbow injury from a fall. And so, the mechanism of the fall I may not have all the details there, but the bottom line is they fell, they got injured, they need, the services we provide. But I'm almost embarrassed to say, and you're asking about younger patients, in the healthcare industry, the number one cause of work comp claims in healthcare are falls. And so that's healthcare workers. That's people that work in hospitals. A lot of which are well compensated positions. So when you get off an elevator, if you slip and fall and hit your head and have a closed injury, and you happen to be the neurosurgeon for that facility and that community, that is a substantial injury.
It's funny. I actually had a case. I was retained as an expert witness on a case involving a surgeon who slipped and fell while in surgery. Apparently, it's a very wet process. You got a lot of fluids on the floor, and he slipped and fell and got severely injured. And he was a high dollar victim. I know it's a workers' comp claim, but it's still a serious problem, serious cost, and just all of his patients that now don't have the benefit of him, being their doctor for a while. So it's really troubling. Real quickly, what's the medical community in general doing about this? I mean, is there a response? I mean, you mentioned hospitals. This is a problem, chronic issue for the medical industry as a whole. So what is the medical community, doctors, et cetera, doing about this problem?
The medical industry in general, the approach is to try to minimize the risks through patient care. So avoiding medications that affect your balance or cognition. Particularly multiple medications in some of our elderly can have cognitive effects or affect their ability to ambulate efficiently. Gait training, balance training are all things that a lot of the primary care physicians will encourage elderly patients to get involved in to try to maintain core strength and maintain balance and stability. Having protective equipment at home or in areas, bathrooms where you're more susceptible for a fall. A lot of times will be done by the home health agencies when they assess patients or their living environments to help them with the activities of daily living, particularly when they're coming into a rehab type scenario after an injury or after an event or surgery. But also, vision is important, proprioceptive feedback with, using canes and walkers and assistive devices to try to give patients a more stable platform that are at higher risk. All of those are focused on the patient, though, because that's what we do in our industries, take care of people. The other issue that we have no influence over really is the environment, other than, say, at home, if patients, avoid rugs or trip hazards or thresholds or have a safety bar in their bathroom or what have you. But it's when they go out into community that, they get injured from a slip, trip, fall type injury that brings them back. And that's to the medical community that's trying to help sustain their quality of life, but also protect them to some degree with preventative measures. In orthopedic surgery, we don't really have any prevention of the injuries. We at least not at this level. We do injury prevention with our athletes with training programs to try to minimize the risk of knee injuries and so forth. But with the elderly, it's really, or with fall injuries, it's really dealing with the problem after it occurs, which is frustrating as a physician because we all want to be preventative in our approach when able, and that's one of those problems that we have no way to prevent that type injury. The bubble wrap around grandma is not a realistic scenario. So,
you have more than probably any other doctor I know kind of stepped up, leaned in, so to speak, and really been much more involved in this subject as a member of the National Floor Safety Institute's board. In fact, you're the treasurer of the NFSI. Your position as serving as the committee chair of the NFSI B101 Committee on Slip, Trip, and Fall Prevention. I mean, you've really done really quite a bit in steering this or advancing, I should say, this subject matter, not only from the medical perspective, but from, just the entire industry perspective. You and I have made several trips to Washington, D.C., working with the Consumer Product Safety Commission on advancing this subject, asking that the government take, action through labeling of floor coverings, mandatory testing and labeling of floor coverings, which sadly we've lost both of our petitions, but there almost seems to be little will by way of government to want to address prevention. You mentioned how the medical community is working towards prevention, not just reaction. But what's been kind of your take, if anything, as far as, the government just doesn't seem to want to engage in this. I've heard from one individual who said, Russ, it comes down to this. It comes down to money. And if we had $1 billion to invest in helping children, live healthier lives and getting vaccinations, and investing $1 billion in child health care versus $1 billion in keeping, as they said, old people alive longer, guess what most people would rather spend that $1 billion on? And it's a sad reality, but somewhat true. This is a subject matter that, from the medical side and cost side, disproportionately impacts the elderly, which it doesn't appear that some people in our government have any interest in really, I don't want to say not protecting them, but they don't want to invest any resources in keeping older people alive longer. And again, you were with me when we went to meet with the Consumer Product Safety Commission, had a round of meetings. But what was your take on that, just from your perspective?
The initiative to try to prevent injuries, I think there's an element of the intangible there. It's hard to measure what you don't see, and so there is a growing epidemic of injuries from because of the aging population we have, and the baby boomers getting into their latter years and becoming Medicare patients, and the tax that puts on the medical industry from a cost of delivery of care to those patients. I'm not sure if the government or even industry has a grasp on what that really looks like in the future, and so the concern in the medical industry is this is a growing problem that we see continuing to sort of snowball with our population growing and with our elderly population growing, because both are occurring, and how we're going to deal with that, or if it's just business as usual, and that's a budget line item, and so we've already planned on that for next year's healthcare costs. I would like to see personally a more proactive approach to multidisciplinary prevention of the medical community, trying to manage those patients that are high risk from a medication, visual field, proprioceptive assistive device aspect, but also industry and community and government taking a more proactive approach with preventative measures, if it's through education or through labeling or walkway safety initiatives to keep people active and minimize the risk of those injuries, because it's a growing problem. It's going to be it's not going away. I mean, everybody that's listening to this probably has had a family member or a close friend impacted by this problem. So it doesn't take long to find that individual and to see the ripple effect if you just start asking questions about how did you deal with that as a son or a brother or a mother or a grandchild with that family member. And so it's very personal to us, but it's very much a macroeconomics problem that our country is going to have to deal with.
Well, we're not dealing with it very well. It's estimated that as a nation we spend in excess of $100 billion a year just on slips, trips, and falls. That number obviously has got nowhere to go but up, because the connection to our elderly population. And in my work as an expert witness, it'll come up where you ask a company, what's your budget, what's your prevention strategy as a company. Again, it's such a serious problem. Pick any retailer; it's our number one form of guest and employee injury. And so you'll ask, well, what's your budget? How do you budget for prevention of slips, trips, and falls? You have policies, procedures. How do you train your people? Real basic stuff. And they usually look at you with this kind of numb glare of, well, what do you mean? Well, I mean, it's a problem. How do you go about preventing it? There's oftentimes little that they do. And so if you don't have a budget for prevention, then, obviously you're going to have to spend that money on the back end for litigation. So, which no company I know actually budgets for lawsuits. But at the end of the day, that's kind of where we are. It's a cost. Somebody's got to pay for it. Every time you go to a grocery store, you're going to spend an extra couple of pennies for bananas because the cost of those injuries get passed along to the consumer. They're hidden in the products. And as long as people are buying bananas and spending a couple of cents more, why change anything? Which is a sad reality. That's kind of the business model on the back end, which just perpetuates the same problem. And, I guess you can call that job security. Well,
I've had people tell me as much as, well, that's what we have insurance for.
Yeah.
And unfortunately, that's a not my problem, not my responsibility type mentality, as opposed to, these are our family members, or they're somebody else's family members, and our colleagues and coworkers, and from my perspective, it should be more of a personal type responsibility, not just another line item in the employee handbook.
Yeah.
So I agree with you that training and education at the corporate level and budgeting is important, but also just personal responsibility. It's not that it's just your responsibility if you fall and you get injured, but to each other as individuals, as humans. I mean, we're a tribe type community. Yeah. We take care of each other, and you have responsibility for your family and for your neighbor.
Well, who was it that said it? Ben Franklin, ounce of prevention is worth a pound of cure. A little bit of work on the front end to prevent people from getting hurt, and it doesn't matter who they are, whether they're elderly people or young people, really does pay big dividends on the back end. At the end of the day, here we are. The problem's getting worse. It's affecting more and more people. The rate of fatalities continues to rise. I mean, 8 million people a year going to an emergency room. That basically says that if you were to go to any emergency room in the country at any time of the day, you're probably going to see somebody who's there because of an accidental fall. I mean, is it that common where it's just epidemic? I mean, is that where we really are?
Yes. There's not many intentional falls.
I mean, I'm laughing because, just think about it. That if you were to ask an average person, someone that's not in this industry, how often, how rare are slips, trips, and falls? I mean, most people laugh. They're like, falls? I mean, slip and falls, what are you talking about? That's, just people faking it. It's quite the contrary. The opposite is true. It's most people that are, that fall and get hurt are not faking anything. They're severely hurt. Many of them, will die as a result of perhaps surgery or some other physical condition, head injuries. I mean, just on and on and on. But yet the perception by our society is it's just not a problem. That's generally what I hear. It's just not perceived as a crisis.
Well, not everybody that falls gets injured.
Right.
But the falls that don't occur don't cause injuries either. So if it's preventable, and a lot of the injuries that do occur from falls are preventable falls, conceivably. And so if you can prevent those injuries, then that's where it becomes difficult to measure to some degree. But that's a prevention of a life-changing event.
Yeah.
Which is significant.
Amen. Well, we've been talking with Dr. Howard Harris, orthopedic surgeon from Texas Orthopedic Specialists. Thanks for coming out today and talking to the audience.
Thank you for having me.
We may have you back. This has been America's Slip and Fall Guy, Russ Kenzior. Thanks again for listening to my podcast. And remember, don't let your next step be your last step. Until then, take care.